Thank you, organizers and chairpersons, for having me here. Uh, I'm going to be speaking about a study which was presented in the ESMO Congress in Paris 2022 this year. This is on IPSOS, which is a phase 3 study of first-line atezo versus single-agent chemo in patients who are non-eligible for a platinum-containing regimen with NSCLC. We've seen that most of the clinical trials which have shown survival benefit in the first line for NSCLC has been with immunotherapy in the high PDL1 expressors and along with chemotherapy in patients with less than 50 but more than 1. In real world setting, we do come across in our clinics that almost half of our patients are coming in with poor performance status. They are elderly, they do have multiple comorbidities, and there can be a potential for poor tolerance to therapy. So given this poor prognosis and limited treatment options, when we are looking at patients with a performance status beyond 0 or 1, this is like a real world situation which we deal in clinical practice many a times. So to address this issue, the IPSOS study was designed. It looked at squamous or non-squamous histology, patients who were platinum ineligible either because of performance status 2 or 3. PS0 or PS1 were permitted if patients were more than 70 years of age with other substantial comorbidities or other contraindications for platinum chemo. Patients with EGFR and ALK mutations were excluded, and patients who had treated asymptomatic brain metastasis were permitted, and almost 453 patients were stratified based on the histology, based on the PDL1 expression. This was by the SP142 IHC assay, by the TC3 or the IC3, and whether the patient had brain metastasis or not. The primary endpoint being overall survival. The randomization was 2:1 to atezo, the standard dose of 1200 every 3 weekly, and the chemo arm, which was the investigator choice, vinorelbine, either oral or IV gemcitabine. And all these patients were treated up to progressive disease. Crossover was also allowed in patients. So the statistical plan was to get about 380 events which were required to result in 90% power, and all the efficacy analysis were done in the intention to treat population. The interim analysis was performed by the Independent Disease Data Monitoring Committee when 304 events were observed, and then it proceeded to final analysis. A look at the baseline characters here. We see that almost 40% of patients are in the age group of 70 to 80 years of age. 75% patients are in PS2. Non-squamous histology is the majority, being 58%. 90% patients did not have brain metastasis. 69 to 70% patients were previous smokers. And patients who had a PDL1 TC less than 1 formed about 50% in the atezo group and 40% in the chemotherapy arm. So these were the primary endpoint analysis of the overall survival, and atezo giving a median overall survival of 10.3, chemo 9.2, a hazard ratio of 0.78, and this is at the median follow-up of 41 months with a minimum follow-up of 32 months. We see here at 2 years, with chemo it's 12%, with atezo it's 24%, at 1 year it's 38 versus 43. In subgroup analysis, when I look at patients with performance status 0 or 1, we have straight away showing that atezo is better. In patient with PS2 also, the point is to the left of the unity. In PS3, the curve is moving over, although the numbers are less. When we look at the histology, irrespective of histology, this drug seems to be working in this poor performance status patients. And when we look at PDL1 expression also, it doesn't seem to be related to the PDL1. In terms of secondary endpoint with the overall response rate and duration of response, we see here the median duration of response with atezo being about 14 months and with chemo being only 7.8. Patients who are achieving a response are about 16.9%, an improvement of around 9% over the chemotherapy. The secondary endpoints with the atezo as well as chemo, median PFS of 4.2 with the atezo, 4 months with the chemotherapy arm, and the subsequent anti-cancer therapy. We've seen that number of patients who've received with any subsequent anti-cancer therapy in the atezo arm, 20% went on to receive subsequent treatment. In the chemotherapy arm, 29%. Most of them received a subsequent immunotherapy. Few of them received chemo. The median duration of treatment with the atezo arm was about 3.5 months. With the gemcitabine, only 2.3, and with the venerelbine, 1.8. Median number of cycles which were initiated was 6. The treatment-related grade 3 adverse events were seen in 16% of patients with the atezo and almost double that in the chemotherapy arm. Treatment-related serious adverse events again greater in the chemotherapy arm as anticipated. However, when we look at adverse events leading to discontinuation of the study drug, it remains the same, 13% across both the groups. So AEs of special interest, these were immune-mediated adverse events, naturally more common, but no new safety signals were seen. And as compared to the historical data of atezo monotherapy, almost similar. Health-related quality of life questionnaire, patient-reported outcomes, these were also better in the atezo arm, and it remained stable, less than 10%, while chemo did show deterioration in terms of cough, in terms of peripheral neuropathy, alopecia, and appetite loss. Time to confirmed deterioration in terms of chest pain, also better with atezo. So in conclusion, the first-line atezo significantly improved overall survival over a third-generation single-agent chemo. The 2-year overall survival rate is nearly doubled with atezo, 12% versus 24%. Overall response rate is also higher with atezo with durable responses. There were no new unexpected adverse events of special interest were identified, and this probably opens up another treatment option for our patients with poor performance status who are not fit to receive platinum therapy. These are my comments in terms of the study design. We know that this was not stratified as per the PDL1. There may be a different biology. This is a good data set of a underrepresented population in patients with who take part in clinical trial. So this data would help us to make decisions in real world clinic. I don't necessarily believe that gemcitabine or navalabine as a single agent is a standard to be compared with. However, with 90% of patients receiving chemotherapy crossing over to the immunotherapy arm, we want these patients to be on immunotherapy for longer to show encouraging results and keep improving their prolongation of life. Thank you.